but thank you so much and welcome this evening.
Yeah, thanks, Liz. And I really appreciate this opportunity. Anytime I have a chance to spread the word about neurologic physical therapy, I'll take it. So I appreciate this a lot. And yeah, so in terms of neuro PT, I kind of dive into that in some of my slides. So I guess I'll just kind of get started and expand on a little bit of some of the differences between what people might think is just traditional physical therapy and how it differs from neurologic physical therapy. So here we go. And so I am Libby Cousins. I am a board certified clinical specialist in neurologic physical therapy. And that is something you can become after you go through your undergrad and doctorate of physical therapy program. I got this specialty certification in 2021, and I have been practicing in the outpatient private practice setting for over 10 years now. It's hard for me to hear that and say that out loud. I have experience in treating people with movement disorders like parkinsonism, ataxia, people experiencing vertigo, who have had a stroke, who are living with multiple sclerosis, migraines, concussions, dementia and Alzheimer's, as well as some other conditions. And just a little bit about myself. I'm located outside of Boulder, Colorado, and I live in a town called Louisville with my amazing family, and we have a great love of the outdoors. So, as you were speaking to earlier, Liz, I'm going to define what neurologic physical therapy is, and we'll explain kind of the thought process that we go through when we're working with our clients. I'd like to define the principles of neuroplasticity and how we apply those to patient care. And then I have some research-based interventions specifically for people who have experienced a stroke or live with migraine headaches that we have some research to prove its physical therapy's effectiveness in helping individuals with those conditions. And then at the end, I hope if anybody has a question, you feel welcome to ask those. So neurologic physical therapy is essentially what we do is we evaluate and treat conditions caused by the nervous system, whether it's a disease like a progressive condition, say like Parkinsonism, or more of an injury to the nervous system, say like a stroke or a traumatic brain injury. And so how that differs, a lot of people are very familiar with this, I go to PT because I have back pain, or I had to have my hip replaced, or I tore my ACL skiing. And those are kind of classical physical therapy reasons you might go to physical therapy. And there's a whole world of us that treat mostly, if not exclusively, people living with neurologic conditions. And so we can care for people of all ages. And so many conditions are experienced in the nervous system in older adults, but I saw a 13-year-old post-concussion today, and so we can see people of all ages. And our main goal is to help improve function and people's ability to take part in activities of daily living. So here is a fairly comprehensive list of some of the conditions that we treat. At the top, you'll see stroke and other incidents involving brain and blood vessels. If there's a tumor, putting pressure, say, on the brain or the spinal cord or other nerves, we've got some experience treating that, whether it's active and presently compressing on the nervous system, or if you've had a tumor resected. We also treat concussion and traumatic brain injury, Parkinson's disease, multiple sclerosis, dizziness, imbalance, and vertigo, migraine and other types of headaches, conditions like CP or cerebral palsy, spina bifida, kind of the more, those are more seen in the pediatric population as opposed to, I don't see it as much in the adult population. We can also treat ALS and other neuromuscular conditions, acute or chronic inflammatory issues going on with the nerves, spinal cord injury, dementia and Alzheimer's, and then functional neurologic disorders. And now this is a very, very comprehensive list. And I will say there are some limitations. Say I work in the outpatient private practice type setting, and I'm pretty limited in terms of how much equipment I have to help support someone who might need a little bit more physical assistance, like say an overhead harness system over a treadmill to practice walking, like some people really benefit from after experiencing a spinal cord injury or that kind of thing. So this is an extensive list, but in most neuro PTs, I would say kind of have a little bit more of a specialty within all these diagnoses. So when we have a patient coming into our clinic, we take a really wide scope. We really zoom out and try to get the big picture of what's going on with that individual. And so we can evaluate, here you'll see a list of many objective impairments that a person experiencing a neurologic condition might have. So strength deficits, balance concerns, gait or walking difficulties, functional mobility, which is kind of a broader view of somebody's having difficulty like standing up from a chair, turning and sitting in another chair. Sensation and how that influences movement. We've actually learned a lot about the importance of normal sensation or how abnormal sensation influences movement patterns. We can evaluate muscle tension. So this is kind of a good example is if somebody living with migraines has a lot of muscle tension in their upper cervical or up in their neck, we can evaluate that through feeling with our hands and that kind of thing. We evaluate posture. We can take a look at reflexes to see how the nervous system is interacting with what we expect to be normal. Sometimes we'll look at range of motion in joints to see if that's limiting someone's function. Skin integrity. This is more for people that are having greater difficulties with mobility, maybe a little bit or a lot more sedentary. And so we're checking to see if there's any issues with ulcers on the body, that kind of thing. Motor control, which is an internal process of practice or experience leading to a permanent change in someone's behavior. So it's kind of this complex process that an individual goes through. It takes a lot of factors into consideration. We can look at coordination. We have ways to assess the visual and the vestibular system. So the vestibular system is our inner ear. It's one of our 3 primary balance systems, which are vision, vestibular, and then the body. And sometimes actually to bring in migraine here, which I tried to do with knowing that people living with CADASIL have higher predisposition to getting migraines. You might have some impaired signaling coming in from the inner ear. And so we have strategies to help people manage their symptoms and kind of talk to your doctor about that as well. We also assess pain as well as cognition, although some of the more intricate cognitive tests are usually performed by an occupational therapist or a speech language pathologist. And I can dive into that a little bit more later. Of course, I focused on PT because that's my profession, but it's also really wonderful to have that kind of multidisciplinary approach, which you're really going to find more in hospital-based settings. But yeah, so this is the ICF or International Classification of Functioning Framework. And I wanted to just bring this up and speak to it kind of generally because it is something that when we're in our physical therapy programs, it's kind of a framework that we work based on and really try to take into the big picture this person that's sitting in front of us. And it's not just their health condition that they're coming in with, but how is that influencing several other factors? So, for example, if somebody has just experienced a stroke, that would be the health condition up top. On the left side, you'll see body functions and body structures, which that list that I just went through, like strength, range of motion, sensation, that's kind of where we take all that objective information and we say, okay, somebody's having trouble lifting their arm up after they've had a stroke, or their foot doesn't lift up off the floor as well. And so we take a look at that. And then we also consider, though, how does that influence their ability to do activities of daily living, essentially. And those would include like walking, standing up from a chair, that kind of thing. So what is that person not able to do that they were previously able to do, maybe prior to the stroke? On the far right side, you'll see participation. And so that is kind of even more broad. How is this health condition influencing that person's ability to function as a mother at home, say, for example, or, be a coworker and go to work and show up at work on time, that kind of thing. So how is the health condition limiting that person's ability to participate in really just life situations more? Environmental factors down on the bottom could be social, climate, relationships, that kind of thing, just external factors that might influence how we approach an individual in their care, and just setting realistic goals and kind of taking into consideration what's going on environmentally around that person. And then personal factors, which include age, gender, socioeconomic status, culture, those kinds of things that, we like to have a little bit of background information on so that we can really treat the whole person. And so to move on to neuroplasticity, this is a really awesome concept that I love discussing. So it's a process that involves functional and structural changes in the central nervous system. And it's the nervous system's ability to change its activity in response to internal or external stimuli by reorganizing itself following something such as a stroke or a traumatic brain injury. And here I have a list of the 10 principles of neuroplasticity. So as neurologic physical therapists, what we like to do is we like to apply these principles to our treatments so that, say, if somebody's having a really hard time doing a very specific activity, we can apply these principles and really hopefully see better outcomes because we're using these principles of neuroplasticity in our approach. So number 1 is use it or lose it. Number 2, use it and improve it, which I like number 2 more than I like number 1 because it's a little bit more optimistic. Moving down, you'll see specificity. So if an individual is having trouble, say, flipping a fried egg over in their pan in the morning, and that's something that they want to be able to do because they have eggs every morning. Kind of a silly example, but doing that specific task is going to be better than, say, stacking cones or, practicing another skill with that hand and upper extremity. Repetition is very important. So it's always tricky. If you've ever been to physical therapy and they say, okay, do 2 sets of 10 repetitions for this exercise to get your whatever muscle group it is stronger, I always have a hard time with prescription because I pretty much say, do it as much as you can without, getting bored to tears, because repetition is really important. And that applies in life otherwise as well. Just, if you're trying to learn a new skill, if you want to learn how to juggle, you got to practice it and practice it and practice it to really get it down. So number 5 is intensity matters. So going all in. You'll hear in a lot of the research these days the importance of high intensity aerobic exercise, particularly following an event like a stroke, or even for individuals, living with parkinsonism. We see that there's a release of a protein by the brain that is very neuroprotective when you get your heart rate up to a certain kind of threshold. So intensity is very important, and the next one, salience matters. I like discussing this with my clients so that we kind of are all on the same page in terms of goal setting with regards to therapy. Liz said at the beginning of the appointment that she's feeling very excited about being able to open a door with her left hand, and that importance of, or the meaningful activities. I always give the example, if somebody wants to be able to go to, say, their grandchild's hockey game, and it involves going up some bleachers and turning and sitting in a narrow space. If I'm going to give an exercise, I want to make sure that that person knows, okay, this is working towards your goal so that you can go watch your grandson's hockey game, say, for example. So meaningful activities are going to promote more neuroplasticity in the brain. Timing matters. So as soon as you can get moving, it's pretty much just don't delay trying to rebuild those neural pathways. Age matters. A younger nervous system is a little bit more plastic than an older nervous system. But you can see there are 9 other principles that we like to focus on as well. Number 9 is transference. So skills might transfer to other tasks, and then interference is this concept that essentially if you kind of, unfortunately, if you form bad habits early on, say if you've had a stroke and you kind of have this compensation pattern, it's going to be hard to break that. It is possible, but if you can kind of start with those reaching patterns with good habits, that's preferred. So moving on, here is a study that I found to kind of describe some of the impairments that physical therapists might find in an individual who's experienced a stroke, and then the interventions that we can adopt to kind of help that individual improve those impairments. So postural control, which is an imbalance or losses of balance, increasing an individual's risk of falling. Some of the interventions we might do, you'll see on the right-hand side, parallel bars, have a patient stand on a wedge board or a board that kind of rocks back and forth. Marching in place, surprisingly, is one of my more favorite exercises because it really mimics, as opposed to just, okay, stand on one leg, marching in place and doing it really slowly really mimics a little bit more functionally how we move in the world. So say you have to stand on one leg for 2 or 3 seconds to take that step up the curb. And so having enough balance for that duration of time is really beneficial. You can also see some diagonal weight shifting, some multi-directional stepping and weight shifting, that kind of thing. And I'm realizing not everyone probably knows what parallel bars are, but essentially it's a way to practice walking, and there's just 2 bars on a bar on either side of you. And those, as I was stating earlier, I am limited in my resources in my clinic in an outpatient private practice setting, but you might be more likely to see parallel bars and that kind of thing in a hospital-based setting. Another impairment that might occur following a stroke is gait changes or walking changes. So treadmill training and task-specific overground locomotor training. So that's a really long way of saying just practicing walking and maybe adding on a cognitive task if that seems to be challenging for an individual. We like to take, again, real life circumstances and apply them in the clinical setting as much as we can. The BW supported treadmill training, body weight supported treadmill training. On the left-hand side, the picture here is of an individual where there's the harness system. I don't know if you guys can see my cursor, but there's a harness system anchored to the ceiling over, and there are a bunch of different types of harness systems that really can support an individual's body weight to do treadmill training. So you can see this person's wheelchair is parked off to the side, and likely they're doing this body weight supported gait training or treadmill training, because this individual probably has a hard time ambulating without that kind of support. So if I ever have a patient that comes into my clinic who would really benefit from this, usually I refer them to one of the local hospitals that has kind of a better setup for this. So that is body weight supported treadmill training. Some sensory changes that can happen post-stroke. Say if you had a right-sided stroke and your left arm wasn't working as well, mirror therapy is shown to be very effective. So sometimes you'll see a mirror box, or just essentially what the therapist will do is put the mirror to reflect the unaffected side. And so it kind of maps to the brain and almost tricks the brain into thinking that is your affected side. And so essentially it's just a way to kind of get those neurons firing and wiring together. Sensory discrimination activities. So if you have reduced sensation because the area of your brain that processes that sensation was impacted by the stroke, then being able to differentiate between what's hot and what's cold, what's sharp and what's dull, these are all things that we can test and, number one, work on to see if we can get some improvement, but also educate our clients about, you need to be aware that your body doesn't sense hot as well as it used to. And so just making sure that there's some safety awareness around that. Another intervention is electrical stimulation, which I personally don't use very much, if at all, anymore. And then the last option is some bilateral simultaneous movement. So just getting that unaffected, again, it's all about moving the unaffected side to try and get that affected side to kind of join in the party there. Unilateral neglect, which is a pretty unique impairment following stroke, but it happens only if the right side of the brain is affected in a very specific region. And it's kind of it's not necessarily visual, it's more perceptual. That person just kind of loses their perception of the left side of their world. And so we can teach active scanning techniques, of course, daily functional activities that involve kind of looking in that leftward direction, optimizing vision and tapping, vibration, brushing, anything to give sensory input to that left side of the body, just to bring that person's awareness to the left side. Moving on down, we've got flexibility and range of motion restrictions that can happen. So say you've got weakness in your lower leg and that foot and ankle doesn't flex up as well as it used to, and it might be causing some difficulty with walking or clearing your foot while you're trying to ambulate forward. So we can work on range of motion, stretching. STM just stands for soft tissue mobilization, which is a fancy way of saying massage, and positioning and splinting if it's necessary, kind of depending on the phase you are within. Because again, the goal is to move towards independence, and sometimes that does mean putting a brace on a person's foot and ankle, just so that that risk of tripping with it's called foot drop, or just a lack of being able to pick or dorsiflex the ankle, pull the toes up towards the shin. So we have a lot of resources that we can hook people up with on that too. So next is muscle weakness, and this is what we're notorious for as physical therapists, is giving lots of exercises, strengthening exercises, aquatic exercise, elastic bands, free weights, Swiss ball. We take into consideration if a person even has access to those things. And I keep my strength-based exercises pretty simple and pretty functional for my clients. And then the last category here is hypertonicity. So whenever there's something going on with the central nervous system, there is often an associated increase in muscle tone that often you want to be discussing with your neurologist and managing that medically, whether it's via oral medication, or sometimes people will be getting Botox injections into different muscle groups, that kind of thing. Important to work with your neurologist on that to help you manage your hypertonicity. But as PTs, we can also recommend sustained stretches, rhythmic rotation. I'm always talking about the importance of rhythmically moving the body because our nervous system loves that. And then METs is just muscle energy techniques. Some physical therapists really love using those as an intervention. So another study that I found really reflect that I wanted to present was that there's quite a wide variety of approaches with regards to the acute management of ischemic stroke, which ischemic stroke is essentially a blood clot that kind of causes a temporary reduction in blood flow to a certain area of the brain. And there's a wide variation in how many patients are getting rehab and how much rehab they're getting and that kind of thing. So this research study cited that variation is attributable to both patient and hospital level factors. So further down, you'll see a bullet point that says, patients with more complex needs and more severe conditions are less likely to have rehab. And then some of the hospital-based factors were just there wasn't an established program for therapeutic intervention in terms of timing, dosage, that kind of thing. Some insurance-related factors that kind of were driving the patient care. But studies did show that patients who receive more physical therapy have a lower risk of hospital readmission within 1 month of discharge. And they further went on to say that a randomized controlled trial is needed to establish, again, that amount and timing necessary for providers to recognize the value and benefit of rehab services. So this was why I was so excited to present on this, because there is a need for more research, but we do know that physical therapy and occupational therapy and speech therapy, there's a lot of good things happening in terms of helping individuals understand the health condition that they're living with, as well as promote independence after that kind of more acute phase. So this was a really wonderful quote. So this was a gentleman who is an assistant professor at Brown School of Public Health. And he says, for stroke patients, rehab services are one of the most important components in providing treatment that helps patients regain for activities of daily living, such as walking or using the restroom independently. So it's really important to start physical and occupational therapy as early as possible. And this kind of recognition was just really wonderful to read and hear from someone in a pretty good institution, and hopefully can spread the word even more. So long-term outcomes for stroke, the first 3 months post-stroke, between 70 and 80% of patients have difficulty walking, but the long-term outcomes show that same 70 to 80% of patients can walk independently. So some predictors of outcomes is getting started and using that involved side, avoiding compensation as much as you can in the movement patterns, early intervention. So that, as you see there, the most spontaneous recovery happens in the first 3 months. And then a lot of the research studies focus on the first 6 to 12 months post-stroke in terms of regaining or getting back to what we call the prior level of function, which is always a goal. And early mobilization studies, some of these were, I didn't go back and read any of them, but when I was in PT school, some of these trials were going on about very early mobilization or early mobilization. It used to be a trend to kind of wait for everything medically to stabilize and to give that individual quite a bit of time. But now we know that getting up and getting moving is vitally important in terms of long-term outcome. And then going back to bring in the neuroplasticity predictors of outcomes. So applying any of those principles to the rehabilitative approach is just very important. And I would say, if you're looking for a PT in your area, a general PT, somebody that's not like, say, a board certified clinical specialist in neuro PT, or even maybe they only have a little bit of experience in neurologic physical therapy, hopefully they're still applying these principles of neuroplasticity, which kind of shines through in other ways, just even through the repetition of exercise you're doing in a more standard approach. But the predictors of outcomes just are really driven by those neuroplasticity principles. And this one is kind of just to highlight that physical activity and some of the benefits of a healthy lifestyle, just to reduce risk factors for stroke. So on the left-hand side, modifiable risk factors, this is published by the CDC. Modifiable are things that are a little bit more in our control. So maintaining a healthy weight, engaging in regular physical activity, avoiding smoking and limiting alcohol, and then controlling your medical conditions with whichever doctor it is that's helping you manage that health condition. And then some of the non-modifiable that are just as they are genetics, family history, age, gender, race, or ethnicity. And so some health conditions are just more associated with some of these factors, and those are non-modifiable. And next, I'll move into research-based interventions for migraine. And so oftentimes this study really focused on musculoskeletal and balance or postural control dysfunction, and how we can help individuals living with migraines kind of manage their symptoms. Again, this is another one just going back to the importance of being with a really good neurologist who can help you manage your migraine symptoms, whether that's pharmaceutical intervention, that kind of thing. So we on the side, I will say a lot of my clients like to manage their migraines as conservatively as possible. And they have found very good results with some of the interventions that physical therapy can provide. So for individuals seeking non-pharmacologic treatment to reduce that frequency and improve the quality of life related to the migraine headaches, we can really have an impact on the muscle tension or musculoskeletal impairments related to neck pain. We also really take a look, like I said earlier on in the presentation, at the vestibular system or the inner ear. If somebody's reporting vertigo or dizziness and balance or postural control impairments, that's something that we like to address as well, just to see if we can have an impact on any of those symptoms, and of course, educate on particularly balance and fall prevention or reduction. The range of motion in the table on the right-hand side there, you'll see if somebody has maybe range of motion limitations, maybe their head turns very well to the left, but then, it doesn't go very far to the right. So we're gonna really figure out, is that an issue with kind of the cervical spine or the neck segments, and do we need to get those joints loosened up? Is it kind of more of a muscle issue and we just need to release some muscle tension, that kind of thing? And accessory movements and tissue mobility, these are, when I was citing this research article, I said, oh my gosh, I have even a colleague at my work who's really an expert at treating migraines and other types of headaches. And he is not technically a neurologic physical therapist, but he's an expert in evaluating the segments of the neck, the thoracic spine, ways to reproduce that headache or resolve the headache. And so he's more of an orthopedic based PT, but again, that kind of goes back to, you can find, as long as you find somebody who knows what they're doing with the specific health condition you're going in with. So posture is always something we take a look at. That forward head posture, we really want to see if there's anything, if it's functional or if it's structural, and can we kind of give you some exercises or just correct that posture. Proprioception, which is a fancy word for saying kind of being able to sense where your head is in space. And so it's kind of a cool test that we do. We'll put like a laser pointer on your head, and there's this big target on the wall, and we'll have you practice some repeated motions and try to get that laser pointer to hit the bullseye on the target on the wall. And then we'll have you do that same test. I'm simplifying this, but we'll have you do that same test with your eyes closed and see if there's an error or a difference between your ability to hit the bullseye with your eyes open versus when your eyes are closed. Does that influence that position? So it's a great test. It's not used widely, but it is a really good, it gives us a lot of information about how you're sensing your neck. Then as we move down, muscle sensitivity of the craniofacial area. So if there's any trigger points in any of your facial muscles, say if you have some jaw tension, muscle tightness and tenderness up around this area in the base of your skull is called your suboccipitals. And I'm often doing suboccipital releases on a lot of my clients that experience headache symptoms. And even if it's providing some temporary relief, I do have a lot of clients that say it's very helpful in terms of symptom management. Sensory changes, that's kind of going back to, this one isn't quite as common. I don't see it as much, but sensitive pressure pain threshold, sensitivity to heat or cold, and are you able to kind of, tactile acuity essentially means if I push here and then I push over here, are you able to kind of tell the difference between those two spots, and are you able to localize those? So just getting a little bit of information about all the different factors that could play in. And strength, function, and endurance are, again, something that we look at. We look at the cervical spine and the shoulder between people call them their wings, strength in those areas, as well as endurance of the neck flexors. You'd be really surprised if we do this test where we have you lie down on your back and kind of lift your head off the pillow and see how, if you're using kind of your deep neck flexors or if you're compensating with some other muscles. And so you can have a physical therapist evaluate how strong and how long you're able to hold that kind of neck flexed position. And that can indicate, it's nice and it feels good to have the muscles loosened up, but we also really want to make sure that everything is strong and supporting your head, neck, and shoulders very well. And here are a couple other interventions that I just wanted to speak to, because these are some interventions that I really focus on in my clinical practice. So manual therapy, dry needling to release muscle tension, and essentially resetting neuromuscular units. That's kind of the way I describe it. So we're just hitting a little reset. And I can speak a little bit more into dry needling if people have questions at the end. A lot of questions come up about that, even in my workplace. Moving down the list, just taking a look at workplace ergonomics or home ergonomics, adjusting the computer, adjusting the mouse. As I sit here looking down at my laptop as opposed to up at my monitor because I couldn't get it to work earlier. Just adjusting those kinds of things that might be influencing posture and muscle tension and that kind of thing. And just kind of more of a preventative approach. I'm a big fan of patient education and collaboration with neurology on whether there's a need for pharmaceutical management or just a need for a prescription or a referral for physical therapy, because you kind of are wanting to take that more conservative approach. So in summary, as neuro PTs, we can help, as you saw, with a very wide variety of diagnoses and the associated impairments. Neuroplasticity is awesome. It's just a really beautiful thing when you see it kind of working with an individual and you're seeing outcomes and seeing somebody going from having all these issues and kind of lacking independence with certain daily tasks and that kind of thing to kind of traveling along with them in that journey towards independence. Targeted exercise, again, just kind of the sooner the better. And at the end of the day, the ultimate goal of us physical therapists is to promote independence for our clients. And that's not just neurologic physical therapists, that's, I think, all physical therapists. But of course, those of us that are working with individuals who have neurologic conditions, we really see the impact on physical functioning in bigger ways. If it's hard to step up a curb or get in and out of a chair or that kind of thing. So we really, really love to help our clients get back to that more independent state of living. And there are some references for anybody that wants a list.
Thank you so much. And thank you for sharing the references. I know you did a lot of research to put this together and it was just so wonderful. So thank you for that. I am so impressed by the impact and the specificity. And yes, so many questions. We have about 5 questions just to kind of help you assess your timing on the answers. I did also want to let folks know that we will have these, while we don't make the slides themselves available or send those out, this will be a recorded presentation and that will be available so people can pause it or revisit it or review it as often as you like. And that'll be posted on YouTube as well as our other social channels, and you're free to share that once that's posted as well. So thank you so much.
Great.
I'm going to jump right in. One of the questions that we had is just about the process of requesting specifically a neuro PT. So is this something that you have to get a referral from a provider, from your primary care provider? How do you identify who have these specialties? There was even a question of like, is there someone in Fort Collins that you can recommend? I know you have possibly a center also in Longmont, which is not that far from Fort Collins, but if you could just talk about how do patients access these services?
Yeah, great. That's an excellent question. So, and kind of a twofold answer. First part would be most of the time it is good to get a referral, and it can be from your primary care physician, from a neurologist. It can even be from a physician assistant. And so depending on your insurance, say Medicare does require a referral, and then Colorado in particular is what's called a direct access state. So you don't necessarily need a referral, but it is good to have one on hand. So if you've seen a physician recently or a PA, kind of getting that process, and you can just leave it very general with that provider and say, I would like a referral to physical therapy. And then the next process in terms of searching for and finding neurologic physical therapists, like I said, so I have, it's called my NCS, which is just you could search for a neurologic clinical specialist physical therapist. There aren't that many of us, especially in this area. And I'd be happy to look for you up in Fort Collins. You can give my email address out, Liz, that would be fine with me, to try and connect this person to someone up in Fort Collins. There used to be a feature on the American Physical Therapy Association website on the neurologic section where you could specifically search for neuro PTs in your area. And I actually went on there probably 2 weeks ago, and it seems like their system is down at the time, or was down at the time, but you can also look for just neurologic PTs through the American Physical Therapy Association website if that functions back up.
Thank you so much. And then I just want to also clarify. So just to confirm, so patients can request this referral themselves. They can also ask for it. Okay, great.
And I think we try to really promote that because it's fascinating how I think physicians might not even be aware of some of the extent to which we can help individuals with neurologic conditions. And so I think sometimes there's a great awareness kind of in the Boulder County area, and we see a lot of referrals from very specific providers. But I will even say, some of the neurologists local in town, I haven't had a patient referred in a decade, and I've been in Boulder area for, a decade. So I think but I've never had a patient that said I asked for a referral and my physician wouldn't, write it for me. So yeah, I think
Great.
advocating for yourself is really wonderful.
Thank you. I think the next question is also possibly a little bit twofold, but it's a bit of what you talked about the as soon as possible. And I think you had mentioned a 3-month, some of the research showing that as much mobility and movement as you can start. But do you have an end point, or is everybody's healing different? Or what time frame would you say for full, and then the twofold part is there a point at which it could be too late if the injury is old or it's something like that?
It's never too late.
Great.
Yes. So the first 3 months is when we see, I think on the slide, it said the most spontaneous recovery, meaning essentially the brain's going to kind of go through its healing process with or without applying these neuroplasticity principles and getting the heart rate up and doing the rehab process. Most of that spontaneous recovery, just that our body kind of takes care of itself, is in that first 3 months. And then a lot of the research studies, back when I was in PT school in 2012 to 2015, the research was really centered around 6 month studies, 6 months post-stroke, and then 12 months post-stroke. And we can really still see some pretty significant functional improvements in that time frame. And I think a lot of what's happening now is there's this recognition for, yes, that's where you're going to see a majority of the improvement, but there's still potential past that 1-year time frame, and there's still potential even past the 2-year time frame. And the hard part is the research. I think these more prospective, like longitudinal studies, those ones that go way far out into the future, it's a little bit harder, I think, to keep track of patients in a longer term sense, that kind of thing. You might have patients dropping out of research studies, that kind of thing. So there just isn't as much in the research in those really longer term studies. Past really 2 years is kind of where a lot of the research stands right now.
That's super hopeful. That's inspiring and further out than I was expecting for positive outcomes to still be possible.
Yeah.
And that kind of segues into this next participant's question. And it really asks if CADASIL could affect these outcomes. And I know that your expertise isn't in CADASIL, but maybe even for some other neurologic conditions, does having a definite or a second diagnosis, or, does that, how would it impact it? Is it negative impact, or what are your thoughts there? Thanks.
Yeah. So that was one of the slides had the risk factors for stroke and the modifiable versus the non-modifiable risk factors, genetics being one of the non-modifiable risk factors. So individuals living with CADASIL. And, I think that could influence, I guess what I could speak to here is actually just in my personal experience. I've worked with individuals that have a vascular form of Parkinsonism. And so these individuals have vascular changes in their brain that are causing the symptoms that are very similar to Parkinsonism. They don't respond to the typical medical management of Parkinsonism. But I still do see some pretty significant improvements in my clients, just in terms of safety and fall prevention and that kind of thing. So yeah, I don't know that I feel confident enough to speak to exactly what the impact of CADASIL would have on like long-term outcomes, but I'm an optimist at heart, and any exercise you can get, any movement you can get, any education you can get to just kind of enhance your health-related quality of life. I think that's because I've worked with a lot of people that have other genetic conditions where their, you know, prognosis is maybe fair. And I can think of a patient who has a pretty rare form of changes in her cerebellum, the balance part of the brain. And, her neurologists were like, yeah, you'll probably be in a wheelchair by the time you're this age. And she's got better balance than she's ever had in her life, after doing 7 years of pretty intensive PT and that kind of thing. So I think it's a matter of getting hooked up with the right person, finding the right, whether it's exercise program, that kind of thing, where you have this non-modifiable risk factor, but then there's also the potential with all the other kind of interventions.
I love that you're speaking to that complementary nature, of what you can do and work with, and also just the hope and the positivity, and never discounting what's possible. So thank you for that.
Yeah.
Next question I have asks if you have heard of an app called Recognize for creating new neuro pathways, and if so, do you have an opinion on it?
I have not heard of that, but it sounds like something I should look into if it sounds like it's speaking to neuroplasticity. So it sounds like something I need to look into, definitely.
Thanks. And then I think I'm just going to close with a comment, not quite a question that I can see in here, but I think it will at least hopefully feel universal to others or relatable to others as well, especially if people haven't yet considered exploring how physical therapy can benefit them, whether it's specifically a neurologic physical therapy or any type of physical therapy. And this attendee writes, due to your webinar, I began to recognize all of the physical therapy that you are doing is what I am also experiencing in my physical therapy. I am delighted to hear that you reinforce everything that I'm working on. Thank you.
Oh, that's
So,
wonderful.
yeah, I think it's really great. I hope others will also really start to look into what could be possible through physical therapy.